I'm really pleased to be able to be here today just to reiterate the great importance of registries as the foundation really for going forward on rare diseases. And we've already heard an excellent example from Katie about how it's worked for cerebral palsy. I just need to see how to move this on. Well, just fundamentally, typically, a registry collects a standard set of information about all individuals within a defined population who have a disease or a set of diseases. So registries are particularly valuable for rare diseases because it tends to be difficult to identify people with rare diseases accurately in routine health records. And we've already heard Alistair Kent talk about the classification issues, coding and classification issues around rare diseases. So what can rare diseases registries tell us? Well, they can tell us how many people there are living with a specific rare disease in the community, very basic information, their ages and their use of services to be used in service planning. They can allow surveillance of numbers of newly diagnosed cases over time to assess whether the incidence is changing and reasons for that. They can collect information on individuals from diagnosis onwards throughout life to allow a better understanding of how the condition develops over time and how this is affected by treatment and care. Very importantly, registries can be used to contact patients with rare diseases when there are new treatments or services available, or when there are opportunities to participate in clinical trials of new drugs. And we heard of specific examples from Katie. And registries are essential for clinical, genetic and public health research. So there are many uses for registries in general for rare diseases. Which uses are more important depends on the condition. There are many different potential models for setting up rare diseases registries. It could be a single registry for all conditions, but more likely a set of related registries all sharing a common core data set. For some purposes, it's important to hold the personal identification details. For other purposes, the registry data can be anonymized. It's possible to link registry data with other health records in order not to duplicate information and to keep it up to date. Obviously, data confidentiality is always a big issue and has been a big issue around the setting up and maintenance of registries at European level as well, as is patient consent. For some purposes, voluntary registration is useful where patients opt in. For other purposes, it's important to be as complete as possible in covering the entire population, and an opt-out system may be more practical. The accuracy and quality assurance of the information are extremely important. So all these issues need to be worked out in terms of developing rare disease registries in the coming years. So EuroCat is an example of how a network of rare diseases registries can work. EuroCat is a European surveillance of congenital anomalies, and we have 40 registries in 20 countries covering nearly 1/3 of births in the European Union. The central registry, as was said, is here at the University of Ulster, and we have a database now of nearly 500,000 records of babies with a congenital anomaly born since 1980. It's a very old system now. EuroCat was set up in 1979. It's one of the oldest continuing public health networks. This allows us to do surveillance of trends over time and research on issues such as risk related to medication use in pregnancy or environmental pollution, or the impact of campaigns to promote folic acid supplementation. Now, looking at this map, you can see that there are 3 EuroCat registries in Ireland, and they cover together about 60% of the births in Ireland, with a plan to expand to national coverage. Wales is fully covered, 100% covered. England is half covered, due also to expand to 100% coverage this year. In Northern Ireland, paradoxically, despite being the site of the central registry for Europe, we have no local registry. And part of the rare diseases plan that's in gestation for Northern Ireland is to establish such a register here. We already have a cancer register, a renal register, a cerebral palsy register, a neuromuscular registry, and others all relevant to rare diseases. but a way to go to cover all rare diseases. So one of the next steps in the plan North and, as I understand it, South, is to take steps towards down the road of covering the range of rare diseases with registries. So why North-South collaboration? Well, as we've heard from the ministers this morning, inevitably for rare diseases, it makes sense to have cross-border service provision. And for that to happen, we need to be able to share information. So registries are really fundamental for that process. Collaboration, whether it's on the island of Ireland or at European level, and preferably at both levels, also allows us to pool data, which is very much needed for rare conditions, especially for research. Collaboration allows comparisons to be made between countries, and that can shed great light on the situation in your own country. It's often only by comparing to other countries that you really understand what's happening in your own. It allows us also to share expertise and resources, which tend to be rare for rare diseases. So in Eurocat, for example, we've developed software which all our registrars across Europe use, which avoids duplication of effort in terms of informatics, but also helps us to standardize data so that we can pool and compare data more effectively. And we also have a common website with interactive tables of data for all of Europe. So again, in a standardized way, we can compare across Europe. So really collaboration, North and South, is a clear benefit when it comes to registries, as all the other issues in relation to rare diseases. Thank you.
Okay. So we've now heard about the imminent publication of the Northern Ireland and the Southern Ireland Rare Disease Plan. So the next steps will be implementation of these plans, including the planning for cooperation between member states, where coordinated action can bring significant added value to national health systems in the context of these European reference networks. So emerging from the work of the Department of Health-led Rare Disease National Steering Group and the 2011 and 2012 public consultations, the National Clinical Programme for Rare Diseases was initiated in December, and you will see the website here. This clinical programme, established under the HSE's Clinical Strategy and Programmes Division, led by Dr. Anya Carl, in collaboration with the Forum of the Royal College of Physicians of Ireland postgraduate training bodies, aims to develop standardised care pathways and models of care with the aim of improving the quality, access and value of services for patients. Our programme manager, Ms. Dervla Gray, is also here today. So the National Clinical Programme for Rare Diseases aims to provide the appropriate clinical expertise for those affected with rare diseases through a national network of centres of expertise, which we've heard about, or for these very rare disorders in collaboration with designated European reference centres. The programme aims to improve the timely access to appropriate diagnosis and care, which should result in decreased mortality, morbidity and disability, improve the quality of life for those affected, and also be cost effective. So moving forward into the implementation phase, the initial focus will be to develop the model of care, to identify and map out the existing centres of expertise here and abroad for diagnosis, multidisciplinary care, clinical research and training. What we've heard about is the need to develop these shared care pathways, particularly close to the point of care and at home, near home, for the common rare diseases, and facilitate the information and helpline access to patients and families through the establishment of a centralised rare disease information office with access to a helpline and the established European information portal Orphanet, and this has come across very strongly as a recommendation from our public consultation process. What we heard about earlier as well this morning is really the need for us to build on our well-established collaborations and cooperations between Northern and Southern Ireland. In particular, we know about the established strong collaboration through the National Centres for Genetics in North and South. And in addition, the National Centre for Inherited Metabolic Diseases and their northern counterparts, and collaboration in cystic fibrosis. And as we just heard here, really the sharing of data in networks and registries. We also have actually established research collaboration, and we know in rare diseases to be effective in clinical research, there are 3 strong parameters of success. One is the collaboration with patients and patient empowerment. Second is the development of registries. And third is having a strong network. So for example, for the rare disease galactosemia, where the outcomes are still disappointing, we are now collaborating in the 17-member European galactosemia network. We're the co-leads of this project, and we're working closely with Dr. Siobhan O'Sullivan in Belfast, and we also hope to develop this collaboration with Queen's University Belfast with an expert, Dr. Timpson, who may be here. So this really, is to show you just an example of one of the opportunities where we can join our resources, not only for clinical but for research, to really improve the patient pathway, to improve knowledge and patient outcomes with the advancement of research and diagnosis with this close collaboration. And lastly, there are probably quite a number of examples of how we can work together. Professor Riddel from Trinity College, a nephrologist, couldn't be here today, but he has made quite a number of advances for this rare autoimmune kidney vasculitis. Vasculitis Ireland has been developed across borders, and you can see this from these pictures here. And what he pointed out, that the point he'd like to make today in his absence, is that there is a huge unmet need when we cannot collaborate and join our resources. So that my understanding is that in Northern Ireland, that patients go to Cambridge, and this is an example of an opportunity which could be developed for close collaboration. There are very many more examples that can be given, but I've asked to be brief, and so I'll now pass back to our Chair, Eileen, for further discussion.